All right, I'm going to go ahead and get started with the lecture on the general surgery chapter, along with some wound closure and management for you and some instrumentation. Let's go ahead uh, and get started. So, this lecture, I'm going to introduce the concept of the surgical ecosystem, which describes how anatomy, surgical intervention, and biological healing all interact during a surgical procedure. Surgery is not simply about removing diseased tissues. Instead, it is a controlled intervention that temporarily disrupts the body in order to restore health and function. Every operation involves three major components: understanding anatomy, performing the surgical intervention, and allowing the body to heal properly afterwards. Surgeons must have an extremely detailed knowledge of human anatomy in order to safely navigate through layers of tissue without damaging critical structures like nerves, blood vessels, or organs. Inside the operating room, the surgery is always a team effort. That's good for surgical techs to remember that. The surgeon leads the procedure, but the success of the operation depends on heavily on coordination of the entire surgical team. This includes anesthesia providers, circulating nurses, and surgical technologists who are responsible for maintaining the sterile field and ensuring the instruments are ready when needed. Surgical technologists play a critical role in the ecosystem because they control the sterile instrumentation environment. They must anticipate the surgeon's needs, maintain proper sterile technique, and ensure that instruments are functioning correctly throughout the procedure. Anticipation is one of the most valuable skills a surgical technologist can develop. Experienced technologists often know which instrument the surgeon will need before the surgeon asks for it. A fascinating surgical fact is that modern sterile technique was not widely adopted until the late 1800s, after Joseph Lister introduced antiseptic surgical methods. Before this discovery, many patients died from infections after otherwise successful surgeries. Today, strict sterile technique dramatically reduces postoperative infection rates. Throughout this lecture, we will explore how surgeons navigate the body, how they access internal structures, how they repair or remove diseased tissue, and how the body ultimately heals after surgery. Understanding the surgical ecosystem helps explain why every member of the operating room team plays an essential role in the patient outcome. Navigating the gastrointestinal tract. This slide introduces the major anatomical regions of the gastrointestinal tract, which surgeons must navigate during many abdominal procedures. The GI tract is essentially a long, continuous tube that runs from mouth to anus, but different regions perform very different functions in digestion and absorption. The upper gastrointestinal tract includes the esophagus, stomach, and duodenum. The stomach itself is divided into several anatomical regions, including the fundus, body, and pylorus. Each of these regions has slightly different physiological roles in digestion. The stomach stores food, mixes it with gastric acid, and begins the process of chemical digestion. Supporting organs such as the liver, gallbladder, and pancreas play major roles in digestion, even though food does not pass directly through them. The liver produces bile, the gallbladder stores and concentrates bile, and the pancreas produces digestive enzymes that break down carbohydrates, fats, and proteins. The lower gastrointestinal tract includes the jejunum, ileum, and large intestine. These regions are responsible primarily for nutrient absorption and water reabsorption. The large intestine includes several distinct sections: the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. For surgical technologists, understanding this anatomical map is extremely important because many procedures involve navigating these structures. Knowing where the surgeon is operating helps the technologist anticipate which instruments will be required and what type of tissue will be encountered. The GI tract is that it contains its own nervous system called the enteric nervous system, sometimes referred to as the body's second brain. This network of neurons helps regulate digestion independently of the central nervous system. When surgeons operate in the abdomen, they must carefully identify each of these anatomical regions to avoid damaging nearby organs and blood vessels. Accurate anatomical orientation is essential for safe surgical procedures. The layers of abdominal defense. This slide illustrates the layered structure of the abdominal wall, which serves as a protective barrier for internal organs. During many abdominal surgeries, surgeons must carefully pass through these layers to reach the operative site. The most superficial layer is the skin and subcutaneous fat, which provide the first line of protection against external injury and infection. Beneath this layer lies Scarpus fascia, a connective tissue layer that helps provide structural support to the abdominal wall. Below the fascia are important muscle layers, including the external oblique, the internal oblique, and transversus abdominis muscles. These muscles help stabilize the trunk and assist with movements such as twisting and bending. The rectus abdominis muscles, which run vertically along the front of the abdomen, are commonly referred to as the six pack muscles. Between the rectus muscles lies a fibrous structure known as the linea alba. This structure is frequently used for surgical entry during midline incisions because it contains fewer blood vessels and nerves than surrounding muscle tissue. Deeper layers include the transversalis fascia, extraperitoneal fat, and the parietal peritoneum, which lines the abdominal cavity. The peritoneum forms a protective membrane around many abdominal organs. For surgical technologists, understanding these layers is essential for anticipating the steps of abdominal surgery. As the surgeon progresses through each layer, different instruments may be required, such as scalpels, electrocautery devices, retractors starting small to large, or suction instruments, possibly a Yankauer, and then moving into a pull suction. A useful surgical fact is that the midline incision through the linea alba is one of the most common abdominal incisions because it minimizes bleeding and provides excellent access to the abdominal cavity. Understanding these layers helps both surgeons and surgical technologists work efficiently while minimizing damage to the surrounding tissues. Tactical entry points. This slide introduces the concept of surgical incisions, which are the entry points surgeons use to access structures within the abdomen or pelvis. The choice of incision is extremely important because it determines how much exposure the surgeon has to the operative field. A well planned incision allows surgeons to work efficiently while minimizing damage to surrounding tissues. The midline incision is one of the most commonly used abdominal incisions. It runs along the linea alba, which is the fibrous structure between the rectus abdominis muscles. Because this area contains fewer blood vessels and nerves, it is relatively bloodless and provides rapid access to the abdominal cavity. This makes it a versatile incision used in many emergency procedures. Another incision shown is the Pfannenstiel incision, sometimes referred to as the bikini incision. This incision is made horizontally just above the pubic bone and is commonly used in GYN surgeries and C-sections. It offers excellent cosmetic results because the scar is hidden below the waistline. The Maillard incision is a deeper, transverse incision that cuts through the rectus abdominis muscles. This approach provides wider exposure to the pelvic organs, but requires careful management of blood vessels within the abdominal wall. The Czerny incision is another specialized approach used primarily in pelvic surgery. Instead of cutting through the muscle, the surgeon detaches the rectus tendons from the pubic bone and later reattaches them. Another incision is going to be your McBurney incision, which is going to be for gallbladders. You have your subcostal incisions. One is for the splenectomy, and then one is going to also be for liver resection. You also have a chevron incision, which comes to a point along the two bottom ribs in the middle, just below the xiphoid process, and is also for a liver resection. For surgical technologists, understanding the incision types helps anticipate which instruments will be needed. The surgical technologist must prepare items such as scalpels, bovies, retractors, and suction equipment as the surgeon progresses through the layers. The incision marks the beginning of the surgical journey. Once access is achieved, surgeons can move deeper into the body to address the pathology. The minimally invasive revolution. This slide highlights one of the most important developments in modern surgery: minimally invasive surgery, or laparoscopic surgery. Instead of making large incisions, surgeons use small ports inserted through the abdominal wall to perform procedures with specialized instruments. To create space inside the abdomen, surgeons inflate the abdominal cavity with carbon dioxide gas, a process known as insufflation. This lifts the abdominal wall away from internal organs and provides room for surgical instruments to move. A small camera called a laparoscope is inserted through one of the ports. This camera transmits a high definition image to monitors in the operating room, allowing the surgical team to see inside the body. Minimally invasive surgery offers several advantages. Patients typically experience less operative pain, smaller scars, reduced blood loss, and faster recovery times compared to traditional open surgeries. However, laparoscopic surgery also presents unique challenges. Surgeons must operate using long instruments while viewing the procedure on a screen rather than directly looking at the surgical field. For surgical technologists, laparoscopic procedures require a different set of equipment. The technologist must prepare a laparoscopic trocar, insufflation tubing, camera systems, light sources, and specialized long instruments. Another important responsibility is camera management. The camera must remain clear and free of debris so the surgeon maintains good visibility. The first laparoscopic gallbladder removal was performed in 1987, and it rapidly revolutionized general surgery. Today, many procedures that once required large incisions can be performed through openings only a few meters wide. Minimally invasive surgery represents a major shift in surgical philosophy, achieving the same surgical goals while causing less trauma to the patient and also reducing the chance of surgical site infection. Instruments of division and control. This slide focuses on instruments used to cut tissue and control bleeding during surgery. These tools are essential because nearly every procedure requires precise tissue division and hemostasis. One of the most commonly used devices is the bovie, also called the electrosurgical unit or ESU. This device uses electrical energy to either cut tissue or coagulate blood vessels. When used in cutting mode, the electrical current vaporizes tissue cells, allowing surgeons to divide tissue quickly. In coagulation mode, the energy causes proteins in the blood vessels to denature, sealing them shut to stop bleeding. Another device shown on the slide is the harmonic scalpel, which uses ultrasonic vibrations rather than electrical current. This instrument can simultaneously cut tissue and seal blood vessels with less thermal damage to surrounding structures. Traditional surgical scalpels are still widely used because they provide extremely precise cuts. Different blade sizes are used depending on the tissue being incised. For example, a number 10 blade is commonly used for skin incisions in abdominal surgery. Smaller blades, such as the 15 blade, are used for more delicate work. For surgical technologists, preparing these instruments correctly is essential. The technologist must ensure the electrical surgical unit is properly connected, verify that the correct scalpel blades are loaded into handles, and confirm that energy devices are functioning before the procedure begins. The first ESU unit, or bovie, was first introduced in the early 20th century by Dr. William T. Bovie, whose name surgeons still use today when requesting the device. Proper control of bleeding during surgery is critical because excessive blood loss can compromise patient safety and obscure the surgical field. Grasping the terrain. This slide introduces instruments used to hold, manipulate, and stabilize tissues during surgery. These instruments allow surgeons to move structures safely while performing procedures. One category includes hemostats, such as mosquito clamps, cryo clamps, and Kelly clamps. These instruments are used to clamp blood vessels temporarily until they can be ligated or cauterized. Another category includes atraumatic graspers, such as the Babcock forceps. These instruments are designed to hold delicate tissue like the intestines without causing damage. The Babcock has a rounded tip and a smooth grasping surface, which distributes pressure evenly across fragile tissues. In contrast, traumatic graspers such as Alice clamps and Coker clamps have teeth that allow them to grip tissue firmly. These are typically used on tougher tissues or structures that will eventually be removed. For surgical technologists, understanding the difference between atraumatic and traumatic instruments is extremely important. Passing the wrong instrument could damage delicate tissues. Technologists must ensure that clamps are functioning correctly and that ratchets lock properly when applied. Grasping instruments are essential because they allow surgeons to control the operative field and maintain visibility while performing precise surgical maneuvers. Visibility and closure. This slide focuses on two critical aspects of surgery: maintaining visibility of the surgical field and properly closing the wound at the end of the procedure. During surgery, the surgeon must clearly see the structures they are working on in order to operate safely. This is achieved using a combination of retractors, suction devices, and proper lighting. Retractors are instruments designed to hold tissues and organs out of the way so the surgeon can access deeper structures. Some retractors are handheld, meaning the surgical technologist or assistant physically holds them in place during the procedure. Others are self retaining retractors, which lock into position and maintain exposure without constant manual assistance. Suction instruments are also essential for maintaining visibility. Blood, irrigation fluid, and tissue debris can accumulate in the operative field and obscure important structures. Devices like the Yankauer suction tip or pull suction allow the surgical team to remove fluids quickly and maintain a clear view. At the end of the procedure, the surgeon must carefully close the wound. Closure restores the integrity of the tissues and helps protect the body from infection. Sutures, staples, or surgical adhesives may be used depending on the type of procedure and the tissue being closed. For surgical technologists, this stage of the procedure involves preparing needle drivers, suture materials, and sometimes skin staplers. The technologist must ensure that the correct suture type and size are available because different types require different materials. An interesting surgical fact is that sutures were historically made from materials such as silk, linen, and even animal intestines, which were processed to create what is known as catgut suture. Modern sutures are often synthetic and designed to dissolve as the body heals. Proper wound closure is essential for healing and minimizing complications such as infection, bleeding, or wound separation. Intervening in the upper GI tract. This slide introduces several procedures used to treat disorders affecting the upper GI tract, including the esophagus and stomach. One of the procedures mentioned is esophageal dilation, which is used to treat narrowing of the esophagus. Esophageal structures can occur due to chronic acid reflux, scar tissue, or certain diseases. During dilation, specialized instruments are used to gently stretch the narrowed portion of the esophagus so that food can pass through more easily. Another procedure highlighted is Nissen fundoplication, which is commonly used to treat severe gastroesophageal reflux disease or GERD. In this procedure, the upper portion of the stomach, called the fundus, is wrapped around the lower esophagus. This creates a stronger barrier that prevents stomach acid from flowing back into the esophagus. The slide also references the use of a PEG tube or PEG tube or percutaneous endoscopic gastrostomy tube. This device allows nutrition to be delivered directly into the stomach when patients cannot swallow safely due to neurological conditions or severe illness. For surgical technologists, procedures involving the upper GI tract often require preparation of endoscopic equipment, dilation instruments, and specialized feeding tube devices. Technologists must also ensure that endoscopic cameras and light sources are functioning properly because visualization is essential during these procedures. GERD affects millions of people worldwide, and Nissen fundoplication is one of the most effective surgical treatments when medications fail to control symptoms. These procedures demonstrate how surgeons can restore normal digestive function without necessarily removing major organs. Gastrectomies and anastomosis. This slide focuses on surgical procedures that involve removing part of the stomach and then reconnecting the digestive tract through a process called anastomosis. When part of the stomach must be removed due to cancer, ulcers, or severe damage, surgeons must create a new pathway for food to travel through the digestive system. One example shown on the slide is the Billroth 1 procedure, in which the remaining portion of the stomach is connected directly to the duodenum. This allows digestion to continue through the normal pathway of the small intestine. Another reconstruction method is the Billroth 2 procedure, which is where the stomach is connected to the jejunum instead of the duodenum. This bypasses the duodenum entirely and is often used when the duodenal tissue is diseased or damaged. The slide also references the Roux-en-Y reconstruction, which rearranges sections of the intestine to create a new digestive pathway. This technique is commonly used in gastric cancer surgery and bariatric procedures. For surgical technologists, these procedures often involve preparing gastrointestinal staplers, sutures, and bowel clamps. The technologist must ensure that the correct stapler cartridges are available because different tissue thicknesses require different staple sizes. Anastomosis must be performed carefully to ensure that the connection is secure, properly aligned, and well supplied with blood. Failure of an anastomosis can lead to leakage of intestinal contents into the abdominal cavity, which is a serious surgical complication. The biliary system and cholecystectomy. This slide explores the anatomy of the biliary system and the surgical removal of the gallbladder, known as a cholecystectomy. The liver continuously produces bile, which is essential for digesting fats. Bile travels through small ducts in the liver that eventually join together to form the common bile duct. The gallbladder stores and concentrates bile between meals. When a person eats fatty food, the gallbladder contracts and releases bile into the small intestine. Problems arise when bile components crystallize and form gallstones. These stones can block the cystic duct or bile duct, causing pain and inflammation and infection. Cholecystectomy is one of the most commonly performed surgeries in the world, and it is now usually done using laparoscopic techniques. During the procedure, the surgeon must carefully identify anatomical structures within an area called the triangle of Culotte. This region contains the cystic duct, cystic artery, and common hepatic duct. Proper identification of these structures is critical because accidental injury to the bile ducts can lead to serious complications. For surgical technologists, laparoscopic cholecystectomy requires preparation of trocars, clip appliers, laparoscopic scissors, and electrosurgical instruments. Technologists must also assist with camera management and ensure that clips used to seal the cystic duct and artery are available and functioning properly. Gallstones affect roughly 10 to 15% of adults, but many people never develop symptoms. Even after the gallbladder is removed, patients can still digest food normally because the liver continues to produce bile. The ultimate reconstruction, the Whipple. This slide illustrates one of the most complex procedures performed in abdominal surgery, known as the Whipple procedure or pancreatic duodenectomy. This operation is most commonly performed to treat cancers located in the head of the pancreas. The pancreas sits deep within the abdominal cavity and is surrounded by several critical structures, including the duodenum, bile duct, and portions of the stomach. Because of this close anatomical relationship, removing a tumor from this region often requires removing several organs together. During the Whipple procedure, surgeons typically remove the head of the pancreas, the duodenum, the gallbladder, and part of the bile duct. In some cases, a portion of the stomach is also removed. Once these structures are removed, the digestive tract must be reconstructed so that food and digestive enzymes can still travel through the body. The reconstruction phase of the surgery is extremely complex and involves several anastomosis or surgical connections between organs. The remaining pancreas is connected to the small intestine so pancreatic enzymes can enter the digestive tract. The bile duct is also connected to the intestine so bile can flow from the liver. Finally, the stomach is connected to the small intestine to allow food to continue moving through the digestive system. For surgical techs, this procedure requires careful preparation of a wide range of instruments. Long procedures like the Whipple often involve multiple instrument sets, vascular clamps, stapling devices, and sutures. The technologist must remain organized and anticipate the surgeon's needs throughout the different stages of the operation. A fascinating fact about pancreatic cancer is that it's often difficult to detect early because symptoms usually appear only after the disease has progressed. This is one reason why the Whipple procedure is such an important surgical treatment option. Despite its complexity, the Whipple procedure can significantly improve survival rates for patients with pancreatic tumors when performed successfully. Appendectomy. This slide focuses on an appendectomy, the surgical removal of the appendix. The appendix is a small finger like structure that extends from the cecum, which is the first portion of the large intestine. For many years, the appendix was considered a vestigial organ with no real function. However, more recent research suggests that it may act as a reservoir for beneficial gut bacteria, helping restore the intestinal microbiome after infections. Appendicitis occurs when the appendix becomes blocked and inflamed, often due to hardened stool known as a fecalith. When the appendix becomes obstructed, bacteria multiply rapidly inside the organ, leading to swelling, infection, and increased pressure. If untreated, the appendix can rupture, releasing bacteria into the abdominal cavity, causing a dangerous infection known as peritonitis. Because of this risk, the appendicitis is considered a surgical emergency. During an appendectomy, the surgeon removes the appendix and seals the connection to the cecum. Many appendectomies today are performed using laparoscopic techniques, which involve small incisions and specialized instruments. Technologists must ensure that specimen containers are available because the removed appendix is usually sent to pathology for examination. Also, surgical technologists typically require laparoscopic equipment such as trocars, a camera system, graspers, and energy devices. Staplers or ligatures are often used to seal the base of the appendix. Although the appendix is small, inflammation in this organ can quickly become life threatening if not treated promptly. Colon resection and rerouting. This slide introduces procedures that involve removing diseased portions of the colon and reconnecting the remaining sections. Colon resections are commonly performed to treat conditions such as colon cancer, severe diverticulitis, or traumatic injury. During the procedure, the surgeon identifies and removes the diseased segment of the colon while preserving as much healthy tissue as possible. After the affected section is removed, the remaining ends of the colon must be reconnected. This reconnection is often performed using a circular stapling device, sometimes referred to as an EEA stapler. This device places a ring of staples while simultaneously cutting a circular opening between the two sections of the bowel. In some situations, the surgeon may create a colostomy instead of reconnecting the colon immediately. In a colostomy, the colon is brought through the abdominal wall to create a stoma, allowing waste to exit the body into an external collection bag. Colostomies may be temporary, allowing the colon time to heal before reconnection, or they may be permanent depending on the underlying disease. For surgical technologists, colon resections require preparation of bowel clamps, staplers, suction devices, and irrigation fluids. Maintaining a clean surgical field is especially important because the colon contains bacteria. Because of this bacterial environment, surgeons take special precautions during colon surgery to reduce the risk of infection. Hemorrhoidectomy. This slide discusses hemorrhoids and the surgical procedures used to treat them. Hemorrhoids are swollen veins located in the lower rectum and anus. They develop when increased pressure causes the veins to enlarge and become inflamed. Common causes of hemorrhoids include chronic constipation, prolonged sitting, pregnancy, and straining during bowel movements. Symptoms can include pain, itching, swelling, and rectal bleeding. In mild cases, hemorrhoids can be treated with lifestyle changes or medications. However, severe cases may require surgical intervention. One common treatment shown on this slide is rubber band ligation, a procedure in which a small band is placed around the base of the hemorrhoid. This cuts off the blood supply, causing the tissue to shrink and eventually fall off. In more advanced cases, surgeon may perform a hemorrhoidectomy, which involves surgically removing the enlarged tissue. For surgical technologists, these procedures require preparation of instruments such as anoscopes, ligation devices, and ESU units. Technologists must also be familiar with positioning techniques because many anorectal procedures require the patient to be placed in the lithotomy or prone jackknife position. Although these procedures are relatively small compared to major abdominal surgeries, they can significantly improve a patient's quality of life. Structural fortification, hernia repair. This slide focuses on hernias, which occur when internal tissue or an organ pushes through a weakened area in the muscle or connective tissue that normally contains it. Hernias are most commonly found in the abdominal wall, particularly in the groin region. The slide highlights the inguinal region, which is one of the most common sites where hernias develop. One anatomical landmark often associated with inguinal hernias is Hasselbalch's triangle. This triangular region of the abdominal wall is naturally weaker than surrounding tissue. When abdominal pressure increases, structures such as fat or portions of the intestine may protrude through this weakened area. There are two major types of inguinal hernias: direct and indirect. Direct hernias push directly through the abdominal wall within Hasselbalch's triangle. Indirect hernias follow the path of the inguinal canal and may extend into the scrotum in male patients. The goal of the hernia repair surgery is to return the protruding tissue to its normal position and reinforce a weakened area. Surgeons commonly use synthetic mesh to strengthen the abdominal wall and prevent recurrence. Mesh facts The mesh acts as a scaffold that allows the patient's own tissue to grow into it, creating a stronger repair. For surgical technologists, hernia repairs require preparation of mesh implants, sutures, and specialized fixation devices. Technologists must ensure that the correct size and type of mesh are available and sterile before the procedure begins. Another important responsibility is assisting with proper instrument selection during the repair phase. Surgeons may use suture, staples, or tacking devices depending on whether the procedure is performed using open or laparoscopic technique. Hernia repairs are among the most commonly performed surgeries worldwide, with millions of procedures performed every year. Successful hernia repair restores structural integrity to the abdominal wall and prevents complications such as bowel obstruction and strangulation. Thyroid surgery. This slide introduces thyroid surgery, also known as thyroidectomy, which involves removing part or all of the thyroid gland. The thyroid is a butterfly shaped gland located in the front of the neck and plays a crucial role in regulating metabolism. The thyroid produces hormones that control how quickly the body uses energy, produces heat, and regulates many metabolic processes. Disorders of the thyroid may include tumors, hyperthyroidism, or enlargement of the gland known as a goiter. One of the greatest challenges in thyroid surgery is the presence of several critical structures near the thyroid gland. Two particularly important structures are the parathyroid glands and the recurrent laryngeal nerves. The parathyroid glands are tiny endocrine glands located on the posterior surface of the thyroid. They regulate calcium levels in the blood. If these glands are damaged or removed accidentally, patients may develop serious calcium imbalances. The recurrent laryngeal nerves control the vocal cords. Injury to these nerves can cause hoarseness or loss of voice. Because of these risks, thyroid surgery requires extremely delicate dissection and careful identification of surrounding structures. For surgical technologists, thyroid procedures require preparation of fine surgical instruments, delicate retractors, and energy devices used for precise tissue dissection. Technologists must also ensure that suction and lighting are optimized because the operative field is small and delicate. Successful thyroid surgery removes diseased tissue while preserving surrounding structures and maintaining normal physiological function. Strategic intentions of healing. This slide introduces the concept of wound healing strategies, also known as healing by primary, secondary, and tertiary intention. These categories describe how surgical wounds close and repair themselves after tissue injury. Primary intention occurs when the wound edges are brought together directly using sutures, staples, or adhesive closures. Because the edges are closely aligned, healing occurs relatively quickly with minimal scar formation. Secondary intention occurs when the wound edges cannot be closed directly. This may happen with large wounds, severe burns, or contaminated injuries. In these cases, the wound heals gradually as new tissue grows from the base upward. During secondary healing, a special type of tissue called granulation tissue forms. This tissue contains new blood vessels and connective tissue that gradually fills the wound. Tertiary intention, also known as delayed primary closure, is used when wounds are initially left open due to contamination or infection risk. Once the wound is cleaned and the risk of infection decreases, the surgeon closes it surgically. For surgical technologists, understanding wound healing is important when preparing closure materials such as sutures, staples, or wound dressings. Different surgical procedures may require different closing strategies depending on the tissue condition and infection risk. Understanding healing intentions helps clinicians select the safest closure technique for each surgical procedure. The initial biological response. This slide explains the first phase of wound healing, which it begins immediately after tissue injury. The body responds rapidly to control bleeding and protect the wound from infection. The first stage is known as hemostasis, which involves stopping blood loss. Blood vessels constrict and platelets gather at the injury site to form a temporary plug. A protein network called fibrin stabilizes this plug and forms a clot. This clot acts as a protective barrier and a framework for future tissue repair. The second stage is inflammation, which brings immune cells to the wound site. White blood cells, such as neutrophils and macrophages, remove damaged tissue and destroy invading microorganisms. Although inflammation causes redness, swelling, and warmth, it is an essential part of the healing process. During this phase, chemical signals called cytokines coordinate the immune response and prepare the wound for tissue regeneration. For surgical techs, understanding these biological responses helps explain why sterile technique is so important during surgery. Even small amounts of contamination can disrupt the healing process and increase the risk of infection. A fascinating fact is that the inflammatory phase of healing typically lasts several days before the body transitions into the rebuilding stage. This early biological response lays the foundation for successful tissue repair. Cellular proliferation and remodeling. This slide focuses on the later stages of wound healing, when new tissue begins to rebuild the injured area. The third stage of healing is called proliferation. During this phase, specialized cells called fibroblasts produce collagen, which forms the structural framework of new tissue. New blood vessels also develop through a process called angiogenesis, ensuring that the healing tissue receives oxygen and nutrients. At the same time, epithelial cells migrate across the wound surface to restore the protective barrier of the skin. The final stage of healing is known as remodeling or maturation. During this stage, collagen fibers reorganize and strengthen over time. Myofibroblast cells often help contract the wound, gradually pulling the edges closer together. Although healed tissue becomes stronger over time, it rarely reaches the full strength of the original tissue. For surgical technologists, this phase reinforces the importance of proper wound closure techniques during surgery. A well aligned wound closure helps guide the body's natural healing process and reduces excessive scar formation. An interesting surgical fact is that the scar tissue may take months to fully mature and remodel after surgery. This stage represents the body's effort to restore structural stability after surgical intervention. The return to hemostasis. The final slide brings a lecture full circle by emphasizing the concept of homeostasis, which is the body's ability to maintain a stable internal environment. Surgery temporarily disrupts normal physiology, but the ultimate goal is always to restore balance and function. From the initial incision to the final closure, every step of surgery is designed to correct disease while minimizing damage to healthy tissues. Once a procedure is complete, the body activates complex healing mechanisms to repair the surgical site. Cells communicate through chemical signals to rebuild tissues, restore blood supply, and eliminate damaged structures. For the surgical team, maintaining sterile technique and careful tissue handling helps support this natural recovery process. For surgical technologists, their work plays a critical role in protecting the surgical environment and ensuring that instruments, equipment, and sterile supplies are properly managed. Every action in the operating room contributes to the patient's ability to recover successfully. An interesting fact is that the human body is remarkably resilient. Even after major surgery, the body can repair tissues and restore function through coordinated biological processes. The surgical ecosystem, therefore, represents a partnership between medical intervention and the body's natural healing ability. Understanding this relationship and different procedures helps healthcare professionals perform safer surgeries and improve patient outcome. That concludes our presentation on general surgery for today. If you have any questions, go ahead and send me a message or post them below, and I'll try to get back to you and answer all of your questions.